Okay, we are now going to talk about something a little bit different. This is shared decision making, and this is different than group decision making. This isn't making decisions together as a group about a patient. This is making decisions with a patient about their own treatment. So, so let's keep going. So today, the objectives are we want to understand the definition, importance, and advantages of shared decision making in medicine. What is it? Why is it important? Why is this going to help us make better decisions? And discuss barriers to shared decision making, as well as understanding different methods and strategies for applying this. So, in general, I, one study showed that only 9% of consultations with surgeons and primary care physicians met full criteria for informed decision making. So, informed decision making is when a patient has received um, information about all the different alternatives and the risks and benefits of each of those alternatives, and they are fully informed about it, and so they can choose whether they want to move forward with it or not. So only 90%. So that means most like 90% um, are not meeting that criteria. Um, and then in another study, the idea of checking for understanding and the involving of patients in decision making is very rarely demonstrated. And that was uh, uh, consultations that were submitted for the MRCGP examination, which is an examination in England, an accreditation examination. Um, so when we so this is something that's very important. One, because it's important, but two, because it's this education is very important because it's not something that doctors are doing very well. Um, so when we look at what is a good healthcare decision, a healthcare decision, I mean, what do you guys think? I mean, a good healthcare decision, someone might say um, it's based on evidence. Someone might be it results in a good outcome. Someone might say that it's something that makes the patient happy. It's so a lot of people might have a different idea of what a good healthcare decision, and depending on your answer for what is a good healthcare decision, you might base your practice on that. But really, it's a pretty broad thing that really makes a good healthcare decision. One is it has to be well informed, um, like by supported by evidence. It has to weigh the pros and the cons, like the good things and the bad things, and it has to be compatible with the patient's values, and it has to be practical. Like you have to actually be able to put this decision into practice, or it's a useless decision. Um, so when we can break that down, the first part is evidence-based. We're going to talk more about that in the next session. Um, the um, the next part of this statement is that we need to be able to weigh the pros and the cons and decide which decision is the best. We've talked a lot about that in our first four sessions, like on how do we come up with alternatives, how do we decide which ones are better than the others using analytical reasoning as a complement to intuitive reasoning. How do we go through the steps of making a decision or problem solving, or yeah, so we've really talked about that a lot in the first four. And then this last part is compatible with patient values, and that's really what we're going to talk about this session. Because if a decision is not compatible with the patient values, it's actually not a good decision. So, as always, a lot of people might have different definitions of what is shared decision making. One is the process of patients interacting. And like I always say, you do not have to memorize all the definitions. I want you to understand the idea. Um, and so the process of patients interacting with their healthcare providers and making healthcare decisions. So the idea of patients being involved. Um, Next one, involvement of patients with their providers in making healthcare decisions that are informed by the best available evidence about treatment or screening or illness management options, about that they are involved in making decisions that are informed um, about the best potential benefits, treatments that have the most potential benefits and the most harms, and that they can and that the patient's preferences are actually involved. That's a long one, but the main idea there is that they are involved in every step of the way, as well as their values are being involved in every part of the decision. An individual being an active member of his or her disease management team, so there's the doctor, there's the nurse, there's the surgeon, and there's the patient, and they're all deciding together how to manage the disease. So it's combining patient preferences with evidence-based medicine. This is not when we say shared decision making, we don't mean just let the patient do whatever they want. We mean we're combining those preferences with the best evidence. So in general, the patient and doctor are both involved. That's the main idea here. So what's the right answer in this situation? A 65-year-old woman, she comes to your clinic complaining of blood in her stools for 6 months. She's very tired, and she says that she doesn't want any tests done, and she is ready to die. What should you do? What are just any ideas of what you could do? So I want you guys to think about what are different possibilities of what you could do. So here's some of the options. There's infinite others. There's many, many others. But one is you could say, okay, obey her wishes and send her home. And say, okay, that's what she wants. I'll let her do that. We could just kind of ignore what she said, and we could just say, like we need to. We know that she doesn't want everything, but we'll just order some blood tests and tell her, hey, this is really important. You need to get this done. C, you could order a colonoscopy and tell her she needs to get that done. Just kind of say, hey, this is important. Just this is my recommendation. D, we could just ask her son. Well, she doesn't want anything. She wants to die. What do you want us to do for her? E, you could ask her, why don't you want to get any more tests done, and why are you wanting to die? And you guys might have some other options too. I mean, there really is limitless possibilities here. Even how your tone of your voice is, how much time you spend with the patient, all of these things could be different options. So, in the end, you decide to ask her why she doesn't want to have any blood tests or a colonoscopy. She tells you that she does not have any transportation to get to a lab, and she said that one of her friends died during a colonoscopy. So can you see here why this was really important that you just ask her more questions? I really like when you're asking the question why, you might be very surprised. You might be assuming what her answer is she just wants to die, and she's depressed and she wants to kill herself. That might be what you are thinking. So in that case, you might have a different idea of what you should do. But if you just ask her and talk to her, you see now that she's more concerned that she doesn't have she just knows she can't get it done. And then and then also she has this fear that one of her friends died during a colonoscopy. So what's the next step to do? So, or maybe before that, what would have happened if you would have done any of these others? If you just sent her home, what would be the possibility? Like, she Um, if she ended up having cancer, maybe she would die, or maybe if she continues to have the bloody stool, or definitely whatever she has is going to get worse. Um, if you would have just ordered a blood test and or ordered a colonoscopy and just tell her, hey, you need to get this done, she's probably not going to go get it done, um, because she wasn't involved in the process. She told you she didn't want to do it. You're telling her you have to do it. Is she going to listen to you? Probably not, because she just already has a reason why she's not wanting to get it done. Um, uh, this is really addressing the idea of a patient's autonomy. Like they have the right to autonomy means a self-rule, versus like a democracy or a theocracy or a monarchy where the king rules or the religious leader rules, or in a democracy like a voted leader rules, um, but with input of the population. Um, but in autonomy, it's really she has the right to make decisions about her health care. And by B and C, you're really taking that away. Um, and we'll talk about some of these even in ethical situations. But this A goes against the idea of beneficence, where it's like we're trying to do something good. This is we're not doing our best trying to do something good if we're just sending her home. Asking her son what he wants you to do. Uh, this is fine if she's okay with you talking to the son, but if you do not have consent to talk to the son, then this is really violating her rights as a patient uh, to privacy. Um, and then, but just by asking her what other tests, or why don't you want her to get any tests, or why are you wanting to die, you can get a lot of information, which you did. And so, what do you want to do now? So, maybe some different options. At this point, you could say, well, I'm going to order the blood tests and the colonoscopy and tell her, well, try your best. Um, Dabar halik. Um, and then B could be a brainstorm with her about possible ways she could get to the lab. Like brainstorm, I think we talked about this in another lecture, and maybe you already know. It's just come up with as many ideas as possible um, uh, that she could get to the lab. Like you talk about, well, could you take a taxi? Could you get an Uber? Could you take public transportation? Do you have a relative or a friend that could take you? We could just jump directly to asking her son, could you take her to the lab? Um, uh, and then you could explain the risks and the benefits of the colonoscopy. Um, uh, and so maybe she has a more informed consent about it, more information about it. Or we could ask her more questions about her friend who died. Like, what happened? Like, what was your um, uh, do you know how she died? Was it really during a colonoscopy? Um, was it something else? Or I think you guys can come up with some other options too. So, and there's not even on these options here. I don't know if there's one answer that's correct where the others are wrong. Maybe you can do multiple ones of these. So, when you're talk to her about, you decide to talk to her about the risks and benefits of a colonoscopy. Because right now she's making the decision not based on being well informed. And so when we're talking about here, what makes a good decision? Okay, we're going with the patient values, but she's able to sort of weigh the pros and cons, but it's not based on any evidence. Like we want to provide good medical care, and so we want to inform the patient so then they can really do a better job at saying what are the benefits and the risks of doing this. Because she might have no idea that if she doesn't get this, she might be have no idea that if she doesn't get this colonoscopy done, that she could die. And so if she comes back later and says, well, the doctor never told me that I could get cancer or that I could die if I didn't have the colonoscopy, and if she gets really sick, she could definitely sue you because you have not given her informed consent. Um, okay, so um, you talk to her about the risks. You talk to her about how important the blood tests are. You say that like it's very rare that any bad thing happens during the colonoscopy. I'm going to send you to a doctor that has a lot of experience, um, and hopefully we can figure out what the problem is, and he can sometimes just solve the problem um, if during the colonoscopy. You're going to be asleep during the colonoscopy, so it doesn't cause any pain. Um, um, there is a small risk of the like perforating the colon or like poking a hole in the colon, but this is a very small risk if the doctor has done a lot of colonoscopies before. Um, so you also the son tells you he can drive her anywhere she needs to go. So it sounds like she was just afraid to ask him, but now you've solved that problem. Um, in the end, after you've talked to her for a while and she understands the risks and the benefits, she says she's still afraid of the colonoscopy, but she'll think about it. But she does agree to get the blood test done. So that's pretty good. You've solved the blood test problem, you've solved the driving problem, but she still won't get the colonoscopy. What do you do now? So here's some more options for you. Insist and say, that's great that you're going to go to the lab, but you really need to get a colonoscopy. B, you set up an appointment without telling her, and you just tell the son to bring her to the colonoscopy, but to not tell her that that's what she's getting she's getting the colonoscopy. So kind of like just get her to the appointment without telling her. C, you could just say, okay, that's fine. This is your choice. You get the labs done, and whatever. You're thinking about the colonoscopy. D, maybe this is similar but a little bit different. You could say, okay, but really emphasize the importance of the colonoscopy, and then set up a follow-up appointment to go over the blood tests and see if she has changed her mind about the colonoscopy, or maybe you can come up with other options. Um, so A, in this one, you're really just kind of forgetting about the patient preferences. Like she's told you multiple times, she's gone through the conversation that she doesn't want this, and you're just kind of just being very insistent. This one, again, is not taking the patient preferences into account at all. This is she has the right to make an informed decision. She has autonomy. She has the right to know. Um, uh, the just saying okay and just letting her do whatever she wants. It kind of sounds to me what I'm getting at is that you're just giving up on her. You tried, now you're done. When really there are other things that you can do. And so that goes with the idea of beneficence. We're trying to do what's best for the patient. So by doing D, you're saying, okay, the patient has autonomy. She can choose what she wants to do. But we're going to make sure that we're informing her with all the information that she wants so that she can make the best decision. And you're doing something we call safety netting. I think we talked about during the clinical skills course, where you're having her follow up with you, so you can go over the blood tests and you can check to see it. Maybe she's not ready now, but maybe she'll be ready next week, or maybe the month after, if the problem gets any worse. But at least you're giving her a chance to come back and have that conversation with her. Okay, so the important thing about clinical decision making is there's a lot of important things, but one is that a lot of interventions have different benefits or risks that patients might value differently. So one intervention might have a benefit or a risk, but a patient might value that benefit, or might see that benefit or risk in a more strong way or in a lesser way. And do you remember what this was called? I think this is from the first lecture, utility. And so outcomes might be valued by different patients in different ways. So an example of this would be a patient that wants to live as long as possible and is willing to, even if that means being on a ventilator for 10 years, versus a patient that just wants to be as comfortable as possible and wants to, or maybe wants to, like spend as little time in the hospital as possible. So these two patients have very different preferences, and so their treatment might look different depending on this. And often there's no single right answer. Like one example is in hyperthyroidism. There's medicines that you can take, there's radiation that you can take, or there's a thyroid surgery. And the risk of, if you have hyperthyroidism and you treat it with medication only, the risk that the hyperthyroidism will come back after you stop the medications is about 50%. But if you do radiation, the likelihood of it coming back is only 30%. If you do surgery, the likelihood of the hyperthyroidism coming back is 10%. And so all of these are acceptable methods medically and evidence-wise, because if you fail with medications, you can get radiation or surgery later. Or if you fail with radiation, you can get surgery later. And so it's okay. It doesn't have any long-term effects whether someone takes meds or radiation or surgery. They need to know what are the risks and what are the benefits, and then they can kind of choose, you know. And so it's okay. A lot of times there's not one right answer. So we need to know the patient's preferences, and so we can help them come to the best decision together. The ethical principle of patient autonomy. So we talked about that some, where the patient has the right to make their own decisions. This is an ethical principle that is very pertinent to medicine. And when we get into, there's one lecture we'll have on ethics, and we'll talk more about that. But this idea of the patient being involved is, or allowing the patient to be involved if they want, is very important. There's also a legal requirement that we need to have informed consent. Like I said, if the patient comes back and tells there's a lawsuit, like something bad happened during surgery or with a medication or something like that, and the patient says, the doctor never told me that this could happen, and you don't have any documentation that says you did tell the patient that, the patient automatically wins. Like, because you didn't document it, you didn't write it down, that you told the patient that this was a risk. Also, just when we're thinking about evidence-based medicine, or the evidence-based practice movement, we cannot make a fully informed evidence-based decision without the patient's perspective, because that is a piece of the evidence. Like, that's a piece of the information that's going to help us make the best decision. And without that piece of evidence, like their opinion, you know, or their preferences, or their perspective on the problem, we're going to not be able to make the best decision. So this is even important for that. Another thing is that a patient can't be forced. I mean, besides the ethical implications, like we need to give them autonomy, they have autonomy regardless of what we are telling them. They have the right to, we can't force them to do anything. We're not going to go to their house and cook them one type of food and then force them to eat it. We can't force them to take a medicine, even if it's in the hospital. They can just pull out their IV, or they can say, I don't want this. And even if we send them for a surgery or an appointment, they can choose to go or not go. And they're going to be much less likely to follow uh, your recommendations if they're not a part of that process. If you have not checked with them, is this okay, or do you think you can do this? These types of questions, um, I, it's they're not going to be able to they're going to be less likely to implement the change that you're wanting. Um, so also, especially preventative medicine, meaning like screening or vaccines, that really requires a lot of patient empowerment for it to be effective, because we're talking about patients coming to visits or doing tests even when they don't feel sick. So like even if it's vaccines, if this is cancer screening with a colonoscopy, um, I, I, or I, another example is like the tarakomi, the hemoglobin A1C for a patient with diabetes. They're supposed to get this test every 3 months, but if the patient doesn't know why, um, they might just think, well, why am I going to get uh, poked with a needle every 3 months for no reason? But if they know the reason and they're involved in the reasoning, then they might be more likely to do that. The last thing is just they have, just like we said about the autonomy, they have the right to make choices and the ability to act on them. Where they have autonomy, they have the right to choose what they want to do. It's their body, it's their health. They can choose what they want to do. So when we talk about patient empowerment means empowerment is like giving someone power. And so if I empower you, I'm giving you the the authority or the power to to do something. And so when we're talking about patient empowerment, we're talking about that the patient has the power to make choices about their health care. And the justification or the reason why this is correct, or this is the right way of, uh, the reason why this is a good thing when a patient has the right to make choices about their health care is because they are the ones that are experiencing the consequences of both having an illness and treating their illness. So they are the ones that are experiencing the disease and the problem, and so they have the right to make choices about it because it's affecting them more than anybody else. Um, but for them to be able to make good choices about their health care, they need to research and they need to have information so that they can fully understand their condition and the treatment plan. And that's really hard for most patients because there's a lot. I mean, we went to medical school, um, or you are going to medical school. We have all this training and everything. And sometimes it's hard to, even for us, to keep up with all the research. Um, and so, as for patients, man, that is really hard. Maybe a patient is illiterate or can't read, or I can't see very well, or something that makes it, or just they're very busy with their own jobs. Like our job is to keep up to date about medical things. That's not their job. But for them to be able to make a good decision, they need to have a good amount of information about the problem. So my question really is how do we help them do this? Um, like how can we help them more fully understand their condition and the treatment plan? You guys have any ideas? Um, I think the main thing is we need to make sure we're talking to them, and so we need to make sure we're telling them about the risks and the benefits. And so the way that we're helping them do this is this whole idea of a shared decision making, We're using language that they can understand. We're giving them a piece of paper that has easily understandable information about the treatment or about the disease. Um, we are uh, um, asking them questions like, do you understand? Or having them repeat back to us what they understand so we can correct if they're not understanding anything well. Um, Maybe not all patients want the same amount of information, and that's okay, but we need to encourage them as much as possible to be able to make involve them as much as they want to be involved. So if we're looking at uh, different ideas, like things patients might say, and what are different ways that we could respond, let's look at this table. This one patient says maybe he's overweight, and you give him an exercise. You say, you know, you need to um, run for 1 hour a day, and then the patient says, "Oh, I hate this exercise plan. Like this is awful." Um, so maybe the one thing you could say is, okay, well, instead of that, how about just every uh, night after dinner, walk with your husband for 10 minutes? Um, and so that's not all bad. You're giving them a different idea, but you're still telling them what to do rather than involving the patient and understanding the patient. Um, So maybe a better model, a shared decision making model, would be to ask them some questions like, so what do you hate about it? And what would help you do better at it? Like, what is it? Is is it the um, uh, is it uh, too hard? Is it too boring? Do you need someone else to do it with you? Or like, what would help you be better at exercising? Then another patient says, I don't think I can quit smoking. And then so we just give them information. We just say, you know, smoking is the leading cause of preventable death. So really, like that's good information, but I think most people probably know that smoking is bad. That's not the problem. The problem is that they're addicted and it's hard to stop. So in the shared decision making model, we could say, why do you think it's so hard? What has happened in the past when you tried to quit? Or what concerns you most when you think about trying to quit? Like getting them to think through uh, um, and coming up with maybe their own plan on how they could quit smoking. And one last thing is I haven't been able to test my blood sugar 4 times a day. Like if we want someone with diabetes to check their blood sugar 4 times a day, um, maybe an older model might have just been saying, just encourage them. Well, it's hard, but you just have to keep trying. You really need to keep track of it. Um, but a new model would be to just ask more questions because you're not going to know the patient's perspective unless you're asking them questions. So you could ask them, what's preventing you from doing that? Why does it make it so hard? Do you know what the numbers mean? Like, do you know what a high value or a low value mean? Maybe they don't even understand really why they're doing it, and that's making it hard to stay motivated. Okay, before we go into all the steps of shared decision making, let's talk about some barriers that prevent this from happening. Uh, One, we can look at it from the position of a clinician, of the doctor himself. Some doctors feel like it's a challenge to their own physician autonomy because doctors do. They have the right to do something or not do something um, based on their own morals. Like if you don't want to perform an abortion, you should not be required to perform an abortion. If you whatever it is, you know. Um, I, and so some clinicians are thinking that, well, I know what is best, and I don't want the patient to dictate or to tell me what to do. Um, Another thing is just lack of training and practice. Like this is not something that a lot of doctors are trained in, and so they don't have a lot of practice on how to go about doing shared decision making, which is hopefully what we're trying to start in this course today. So another thing is the medical evidence. So, there's so much medical evidence um, on everything. There's just so much medical information. A lot of times it's difficult to pull out um, and understand it and interpret it and then communicate that to the patients. A lot of times it's complicated for us to understand all the evidence and how to apply it to our practice, but it's even more difficult when we're trying to take this medical evidence or information or terminology and explain to a patient um, uh, in a way that they can understand. So we can also look at barriers that come up just by the type of practice that we're in. Maybe it's a very busy clinic and there's just lack of time if there's a ton of patients. Or maybe lack of reimbursement. We don't normally get paid for spending more time with patients. We don't get paid more based on did we involve the patient in the decision. Um, and maybe just even guidelines. Maybe there's different guidelines that we follow in our practice, and we always do it this way. And so, and some of those guidelines might make it more difficult to uh, um, involve the patient in coming up with the treatment decision. Um, with patients, I, I, some patients maybe they don't want to participate in shared decision making. They just want the doctor to make the decision for them. And maybe they just want to have, um, maybe it's not that extreme, but maybe they want to have a different type of role. Like maybe one patient um, wants to make all the decisions, or they want to make none of the decisions, or they want to be involved in certain things but not others. Maybe they want to um, uh, have the doctor make the main decision, but then they want to be able to ask questions about it. And so there's it's important to know what exactly the role does the patient want to play in the process. Um, a lot of times, maybe just patients that are illiterate or don't understand like numbers very well, and so that's going to make it more challenging to get them involved. Um, uh, and just different resource problems, resource barriers. Like, is it practical? Is the test available? Is it too expensive for the patient? Um, like, is this test even available in the country that you're in? Could this patient afford it? Just how practical is it? Does the patient have, could they actually, um, I saw a patient the other day that's a Syrian refugee patient, and he's supposed to go to King Hussein Cancer Center for radiation treatment every day for the next 6 weeks. And so it's not just about cost or availability. Um, it's is it practical? Can the patient take time off work to go every day? Just how practical is it? So different doctors, when they start learning about this, often ask um, a few different questions, and these questions seem to come up again and again. Um, and so some of these right here, like, well, we do this already, right? Like patients are involved, and some other doctor might think like, will it actually work? Like, does this work to provide better care for patients? Does that actually work? And one doctor might think, I don't think my patients would actually want this. Like, they want me to make the decisions. And then what about a doctor? He just says, man, I don't have time. Or, or what if the patient, after I've explained everything and gotten the patients involved, what if they don't do what I think they should do? Um, and those are all very valid questions. Um, Will it work? I think it works a lot better after we have practice with this, and there are a lot of studies that show that this is patients are happier and a lot of times have better outcomes um, when they're involved because they are more likely to actually follow through with the decision. Also, when they're involved, they're going to be less likely to sue the doctor or take the doctor to court for if something bad did happen because they know they were part of the process and they were informed about everything and this is what they decided together. It was not forced on them. For someone that says we do it already, like we talked about before, really studies show that only about 10% of patient encounters involve this type of shared decision making. Um, a lot of doctors might say my patients don't want it, but one study showed that 96% of patients prefer being offered, at least offered choices and asked their opinion. And that doesn't mean that all of them wanted to make their final decision. And in fact, 52% wanted to leave the final decision to the physician, but 96% wanted to be involved in that process. Um, so that even addresses the uh, thing too. What if they don't do what I think they should do? Well, at least in this study, it shows that half of them will leave the final decision to the physician, um, but they just want to be involved. And even if they don't do what I think they should uh, do you just leave them and never see them again? Maybe you do safety netting, you see them again after a week or a month, you have the conversation again and see if they're ready at that point. Or maybe they try something and then, like we say, okay, like how about you try to go exercise for one more month and change your diet, but if your blood sugar is still high, let's start your metformin at that time. And so, like the medication for diabetes. And so, if you can come up with some shared decision, okay, maybe they'll do something, and then, but maybe they'll be willing to take the medicine or do what you think if their idea does not work. And really, when at the end, the patient has the autonomy, like we said, to make the decisions about that are affecting their health because they're the ones that are having to live with it. And the last one here was the I don't have time. Um, a lot of times with practice, this does not take much more time than any other decision. And really, if we're trying to do what's best for our patients and not have them come back to us for, say, I didn't understand what medications you wanted me to take, the patient's probably going to come back and have more problems if you have not involved them. So maybe you have to invest more 1 minute longer of your time right now, but you're going to save yourselves 10 minutes later. And so it's about working smart, not just working quickly. So when we talk about self-care, the definition of self-care is the way that people with these long-term health conditions deal with managing their own health. So if someone has anxiety, it's the way that that person is caring for themselves to manage their own health. Maybe they take vacations more often. Maybe they take a medicine. Maybe they meditate every day. Maybe they pray more. Whatever it is, ways that they are helping with their anxiety. Self-care support, on the other hand, are ways that that person's friends or their caretakers or relatives or the healthcare system, like the doctor or nurse or the hospital, is supporting that person with long-term problems. Um, I, or it could even be there could be someone that has bad self-care support, where they don't have friends that are supporting them, or they don't have a doctor that is supporting them. Um, so when we're working with patients, we're really trying to encourage them to come up with ways where they can help deal with their long-term health condition, as well as uh, being that support from the outside to help the person that has the problem. Um, so when we look at domains of self-care, we can look at it in three different areas. We can look at it as like my condition. So like I have diabetes. That's my condition. The way I feel or psychological, okay, it makes me scared sometimes if I'm going to have a heart attack. It makes me feel tired and fatigued, maybe kind of depressed. And then what I do, my social or behavioral, like how does it affect um, uh, my life? I have to check my blood sugar more. I can't eat whatever I want. These things. And so when we're thinking about caring for a patient, we need to care about the whole person, not just get the blood sugar down. And so we need to work on um, how is the patient feeling? How is this affecting their life? And so when we're teaching patients how to care for themselves and supporting them in their role of self-care, we need to be thinking about all of these things. And so that's one reason when we're talking about shared decision making, if I'm just telling a patient, okay, do this, I'm really focusing on just their biological condition. But when I'm talking to them about, well, why is it hard to take the insulin? What are you afraid about? Um, uh, is this a practical thing? Like, is there anything practical or just in the way you're living your life that's making it hard to take the medications? So we need to be involved in all of these areas so that the patient can take care of themselves and so that we are taking care of the patient in all the different areas. So the patient can be providing self-care for himself and that we can be providing self-care support. And so when people that are going to be providing the best self-care to themselves, they're often optimistic, and so they have a good positive view of the future and of the treatment option. Um, uh, and then they're determined, like they actually want to get better and they're going to stick with it. They are informed, and so contextually informed means health information that makes sense to me. And so this is not just being given, um, like if I am telling you about you have gallstones and I say we have to do a lap chole, which involves us doing a laparoscopic surgery under cameras to remove the gallbladder, you might not understand all the words. But if you say we're going to make 2 or 3 tiny cuts in your stomach or in your abdomen, and we're going to stick a camera in there, and we're going to be able to remove your gallbladder that way, and then there will just be one stitch in each of the cuts. You have a better idea of what's happening. So also people that are providing the best healthcare are more confident. They're problem solvers and decision makers, and they're part of good social networks, meaning they have friends or family around them that are supportive. So um, we're hoping when we're doing shared decision making, we can come to a point like if the person does not um, want to take insulin and they don't think it's going to help, they are not optimistic about it, they're not very determined about it because they think it's probably going to fail anyways. So as soon as something is hard, they're just going to stop. Um, if someone doesn't really know how the insulin is helping them, they're not going to be doing it. And if they're not just part of the process, if they don't have people around them to help them, they're not going to be able to continue taking it regularly. But if someone has been come to a decision with the doctor that this is the best method, they are informed about it, they're going to be more optimistic and determined to really keep doing this forever. They're going to be more confident in it. They're going to have, and then hopefully, even in the process, you can help them involve their family or friends to help them with the problem. So when we look at steps uh, uh, to do shared decision making, it looks something like this. And this is a little bit more wordy than I would like, but first thing, develop a partnership with the patient. We're going to do this together, and we're going to go through some examples of this. And then we're going to look for what are the patient's preferences for information. How much information does the patient want to know? Do they want to know everything, all the studies? Do they want to just know the bare minimum? And then we want to establish the patient's preferences for their role in the decision making. Do they want to make the decision? Do they want you to make the decision? Um, we want to ask about and respond to the patient's ideas, concerns, and expectations. So if the patient has any ideas or concerns or expectations, we want to ask them about it so we can know. And then we want to tell them about it. Like, okay, like if they have an idea that's completely wrong, then we can tell them, like, no, no, okay, no, it's not. They came in with fatigue. They think they have cancer. We could say, okay, no, we don't think that. Like, okay, we'll check for everything, but we don't think that. That's not the main thing that's coming to my mind. So identifying choices, including the patient's ideas or his choices, what he wants to do. And then, so just this is about identifying all the different alternatives, really. And then evaluating the research evidence in relation to the individual patient. And so we take all the possible things that we could do, the patient's ideas including, and then we evaluate the evidence based on this specific patient. And then we can show the patient that evidence, or we can show him how to look up the evidence, taking into account points 2 and 3, which is how much information do they really want and what role do they want in this decision making. If the patient doesn't want a lot of information, then maybe you can just give them a little bit. But if the patient really wants a lot of information, maybe you can just give him a website to go to where he can read more about the problem. Number 7 would be helping the patient assess the impact of alternative decisions with regard to their values and lifestyles. Like, how will this one decision weigh in the pros and cons? You know, like what are the positive, the benefits, what are the negative possibilities when this decision is made, and like if a person really values being comfortable and not being in the hospital, you can talk to them. Okay, well, if you're going to get chemotherapy, that means you have to come to the hospital every week. Um, but you also said that you want to get rid of this cancer. And so this is the best way to get rid of this cancer. So you can help them, talk them through what is the best option for them. Number 8, make or negotiate a decision in partnership and resolve any conflict. So you make the final decision together, hopefully, and then if there's any conflict between what you think and they think, maybe you can come to some compromise, like we talked about with insulin, maybe or diabetes medications. Okay, you want to not take medicine yet. How about this? How about you try to exercise for 1 more month? If you can get your diabetes under control, we won't start medicine. But if it's still out of control, then we're gonna start medicine. Does that sound good? And then, okay, you agree upon the plan, and then you complete the follow-up arrangements. Like you, okay, do the test or give the medicine, and then have them follow up in another week or month or whatever you need to do. So if we look at this first practice case, we have a 55-year-old man with newly diagnosed hypertension, and his current blood pressure is 180 over 100. So maybe if we're going to do this first step, we want to develop a partnership. We can say, you know, we can help solve this problem together. Maybe we can tell him that. And then we can ask him. So number 2, establishing the patient preferences for information. Do you want me to give you a lot of information about hypertension, or do you just want to know the basics? Um, and then about the preferences for their role. Do you like to be involved in choosing your own treatment, or is this something that you're fine with kind of me telling you what I think is best? Um, and then ask about and respond to the patient's ideas, concerns, and expectations. We need to ask them, what ideas do you have about hypertension and how to treat it? Is there anything that concerns you, or do you have any expectations about this? I think you guys we've trained you in that pretty well. And then you can respond to those as well if they have any ideas or concerns or expectations. So number 5, identifying the choices. Okay, we could start one medicine today because this is like when we look up the guidelines for someone that has a very high blood pressure, like 180/100, you can choose to start one medicine and bring them back, or you can actually choose to start 2 medicines at the same time. And so we can ask the patient. Both are evidence-based and both are fine. So we can ask him, we could start 1 or 2 medicines today, as well as starting you on a diet and exercise program. Um, and then when we look at um, presenting the evidence to patients, we could say, you know, diet and exercise, it is important, but studies really show that you will also most likely need to take a medicine as well, even if you change your diet and exercise, because your blood pressure is so high that diet and exercise, it is important, but we need to do that with medications. Um, and then number 7, help the patient assess impacts of the different decisions. So like weigh the pros and the cons of decisions. So you can tell them, if you take the medicine without changing your diet or exercise, your blood pressure is just going to get worse. Alternatively, if you just do the diet and exercise and you don't take medicine, then your your hypertension probably isn't going to get better either. So there's the pros and the cons about that. Um, and then you're going to negotiate a decision. So you guys kind of decide together, okay, well, how about let's just start one medication today, and then let's also talk about how you think you can work on your diet and exercise. So he decides that, okay, I can start walking 10 minutes a day after dinner. And then the follow up after that, number 9, is let's set an appointment for about 2 weeks from now. So that sounds like a lot when you look at it by all the 9 steps, but really that can take place in just a few minutes. So another idea, a 45-year-old woman, or a woman-man, I don't know what that is, a woman with diabetes. She already takes metformin and glyburide, but her blood sugar is still high. So we're thinking, this person probably needs to be on insulin. Um, we could tell him, this woman, this is a tough problem, and I think, but I think together we can really help solve this problem. Um, and then if we go back to understanding the patient's preferences for information, and then number 3, preferences for their decision and their what role they want to have. Has anyone talked to you before about what diabetes is or how to treat it? And then if she says no, you can tell her more about it. Um, uh, do you like to be involved in kind of choosing your treatment? And then what about the ideas and expectations? What are your ideas about why you have diabetes? Um, um, why and how best to treat it? Was there anything that concerns you about the diabetes? Do you have any expectations about the treatment? Maybe what concerns you about the treatment? Like maybe she is really afraid of needles, and or she doesn't think she can give herself an injection. So those are important things to know about. So when you're coming up with different ideas, the different alternatives, we could start insulin today, as well as starting you on a diet and exercise program. But it turns out that so that's what we want to do as the doctor, but the patient prefers just doing a diet change. And so then you can talk about the pros and cons, the good benefits and risks of each decision. You can say, diet and exercise is important, but studies show that you will most likely need to take insulin no matter how much you change your diet and exercise. Um, and vice versa too. Like if you just take medicine without changing your diet, the diabetes will likely get worse. Um, so go back here again. So we've identified the choices, and then we've presented the evidence, and then we've said, okay, these are the impact that different decisions can have on you. And then we're going to negotiate a decision, and we're going to say, okay, how about this? Let's work on your diet or exercise for one more month, but then in another month, we'll see how that's going. And if it's still high, I think maybe we should consider insulin at that time. And so the patient says, okay, and then we set up an appointment for another month to recheck her blood sugar and her weight and see how it's going. Um, okay, uh, that is the end of this lecture. Um, uh, and let me know if you have any questions about this. It is a pretty tricky process, but I think if you follow along with some of these steps, you can start doing them very quickly. But I don't even as much want you to memorize the steps, although the steps are very important. I just want you to know the idea is okay, first step, we're going to do this together. Second step is we're going to be talking about the patient's preferences. How much information do they want? What role do they want to have? And then we've already, like, you guys are so good at getting the ideas, concerns, and expectations, all that information out on the table. And then we're going to come up with all the different alternatives. We're going to talk about the evidence that's available so we can figure out what choices are the best, maybe. And then we're going to discuss with the patient what are the pros and the cons, the benefits and the risks of each decision. And then we're going to come up with a decision, and then we're going to do a follow-up. It's very similar to the decision-making and problem-solving steps, and so hopefully you're kind of getting that idea by now. Okay, take care.